Dr. Justin, please. Dr. Justin is going to present the spectral domain optical coherence tomography in the diagnosis of primary open angle glaucoma. Dr. Poonam, you can come up in the next one. Okay?
Good morning. I am presenting my study on SDOCT in the diagnosis of primary open angle glaucoma. So in India, 11.2 million people have glaucoma, out of which 6.48 million people have POAG. Automated perimetry, also known as the HFA, was initially used to diagnose POAG. But this instrument had a problem with it. That is, it detected glaucoma only when 30% of the ganglion cells were already lost. So this is where SDOCT comes into its play in the field of glaucoma, especially with its parameters GCC and RNFL. But there are very few studies which were able to tell about the diagnostic capability of the GCC and the RNFL. It is for this reason that we have taken up this study. So my objectives were to determine the diagnostic capability of ganglion cell complex thickness and the RNFL using SDOCT in patients with POAG, and to determine the association of the structural and functional damage in POAG. Going on to the methodology, it's a cross-sectional study with a sample size of 90. Participants from the PIMS ophthalmology OPD were recruited after satisfying the inclusion and the exclusion criteria. They underwent a complete clinical examination, and then they were subjected to SDOCT and the HFA, and all the parameters were recorded. Going on to the salient results, out of the 90 participants, 43 were males, 47 were females. Age of presentation was between 42 to 85 years, with the average age being 55.63 plus or minus 12.5 years. So overview of the parameters, you can see that the average GCC thickness and the average RNFL thickness were quite similar. The AIOC curves were used to determine the sensitivity and the specificity of GCC as well as the RNFL thicknesses, which were 70.8% and 98.1% for GCC respectively, and for RNFL it was 82.7% and 91.7% respectively. One-way ANOVA test was used to find the association between the visual fields and the GCC and the RNFL thicknesses. For this purpose, our population, for the purpose of analysis, our population was divided into 3 groups based on the severity, as you can see over here. And you can see that all the values were statistically significant. And you can also note that the mean in the 3 groups between the average GCC and the average RNFL thicknesses were also very similar. To reaffirm the one-way ANOVA test, a post-hoc analysis was also done, where the difference in the thicknesses between one group and the other 2 groups were also compared for both GCC as well as the RNFL. And again, you can see that all the values were statistically significant, both for GCC as well as the RNFL thicknesses as given in these tables. Moving on to my discussion, the average GCC and RNFL thickness were around 79 microns, very similar. GCC thickness with RNFL also have an equivalent sensitivity and specificity, as I had mentioned in my AIOC curves. Thereby, the difference in the diagnostic potency between the 2 parameters being statistically negligible. So from this, my study corroborates the diagnostic ability of both these parameters equally. The means of the average GCC and RNFL thicknesses were very similar across all values of IOP, reinstating the equipotent diagnostic capability. The p-values obtained by the one-way ANOVA test proved to be significant, indicating that there is significant association or correlation between the GCC RNFL thicknesses and its respective visual field defects, which was again reinstated by the post-hoc analysis as well. So, but there was a limitation to my study, that is, we hadn't measured the central corneal thickness, which usually has a significant influence in diagnosing primary open angle glaucoma. So to conclude, both average ganglion cell complex thickness and average retinal nerve fiber layer parameters have equal diagnostic capability in diagnosing POAG. Both average GCC thickness and RNFL thickness parameters have significant association too with the visual field changes in POAG. So these are my references that I had mentioned here. Thank you.
Dr. Justin,
Yes,
just
ma'am.
in a nutshell, can you please tell me what did you want to conclude in this study of yours? Like, what did you want to, what was the aim?
My objectives or my aims were to find out the diagnostic ability between GCC and RNFL and to see which was actually superior, ma'am. But my post-hoc analysis, one ANOVA test as well as my AAU ROC curves all corroborated to the conclusion that both were equally potent in diagnosing POAG. Nothing was superior over the other.
Were these cases already diagnosed cases of POAG?
Yes, ma'am. We diagnosed it with the help of the HFA, and then they were subjected to the
so when the case is a diagnosed case of primary open angle glaucoma, so what was the need of doing the GSSE and the RNFL thing?
Just to find out the superiority, ma'am. Actually, when my study started, we actually had 3 groups: the normal ocular hypertension groups as well as the POAG groups, among which we wanted to do the elaborate comparison. But my institutional scientific committee did not approve of that, because they wanted to keep it simple, so I had to stick myself to do these the only group in which I used. That's why I had used a post-hoc analysis to convey my one-way analysis.
So primarily this study was just for an education or academic sort of thing.
Yes,
not for any diagnostic purpose, because
yes,
all these cases were primary
yes,
open angle.
And this was across all the IOPs as well, because we know that SDOCT mainly plays a role in the pre-perimetric glaucoma.
Yeah, that's
Otherwise
what I was,
it's taken over by the HFA.
I wanted to come to that actually, but in these cases, they all were diagnosed cases of primary open angle
Yes,
glaucoma.
ma'am. Yes, ma'am.
Okay, it is just a research work that you
Just
actually
a research work to
right.
find GCC
Thank
and
you.